pandemic, and hopefully 2022 will turn out to be a better year. In Parkinson's, we've really seen a re-engagement of clinical research studies. We've seen several new drugs be approved during the pandemic and recently, and the FDA is currently reviewing several more therapies in Parkinson's disease that we may see come out towards the end of this year and early part of next year. And again, a lot of disease-modifying therapies are currently in clinical trials. We have 3 fellows that will graduate this summer from this program. What does that mean? That means that this translates to thousands of patients, that patient lives with Parkinson's and movement disorders are going to be touched because of this program. So they're going to take their expertise that they've learned through this fellowship and be able to deliver the expert care and the newer therapies that are available for Parkinson's and Parkinson's related disorders that we teach our fellows all about. And this is only possible because of Fund a Fellow and everybody who definitely devotes their time, talents, and riches towards this fellowship program. I want to give a really big thank and a shout out to the development team, especially Mark and Claire, for their devotion, especially during the pandemic, how we had to kind of pivot and switch gears a little bit. Hopefully, we'll see how the rest of the year holds out, and maybe we'll hopefully have one of these live in the near future. But thank you for growing with us and being able to bring these seminars to our Fund a Fellow family during this pandemic, but hopefully we'll see this live and in person in the near future. And a real big, huge shout out also to Mr. Shenna and Ms. Buchanan for just their inspiring energy and dedication to Fund a Fellow over the years. Without their energy and their devotion to the fellowship program and the Fund a Fellow family, we wouldn't be here today. And we're looking forward to a new class coming in July of 2022. So today we're going to talk about Parkinson's and Parkinson's progression. We've opened it up so everybody can see each other. So hello to everybody. It's great to see everybody live and in person, because we in some of these previously we haven't been able to see each other. So it's nice to see everybody. And we will open up for questions and answers during the program. We'll definitely start off with some questions that we already have, but definitely make sure to learn how to use the chat. We'll keep an eye on the chat to be able to answer questions. If some of you are a little brave and they want to answer a question during this, we'll definitely open it up at a specific time during the program. But to help me out with this round table, I bring 2 favorites of the Fund a Fellow family. I'm here to help me address these issues that we're going to be talking about, not only treatments or how to make the diagnosis, what things look like, but also the potential for disease-modifying therapies. We have first Dr. Torres Yagi, who is the director of the Parkinsonism and Dementia Clinic and a recipient of the Fund a Fellow family that trained here, and Professor Dr. Charbel, also known as Charlie Musa, who is the scientific director of the Translational Neurotherapeutics Program and the director of the Parkinson and Dementia Lab, who really just has been an inspiration in really just brings just his science and his fund of knowledge of science into these neurodegenerative disorders. And I've been so lucky to be able to work with him since 2013. And it's because of his vision and because of what he's taught me over the years and being able to work together, we were finally able, it took us 6 years, but we are finally able to open up the Center for Neurodegeneration that is now officially open. Our slogan is redefining brain health. And whenever I think about brain health, I think about the things I've learned through the Translational Neurotherapeutic Program, and a lot of the philosophy and the foundations from the basic sciences I've learned over the years from Dr. Musa, and be able to bring that into the clinics and back into research. And Charlie's going to share a lot of the excitement of things that we've done over the future, but now this center now is coming to true fruition, where we can definitely help patients with Parkinson's disease, the Parkinson's related disorders, all the different memory disorders, Huntington's disease, traumatic brain injuries, chronic traumatic encephalopathy, multiple sclerosis, and even other disorders like ALS, frontotemporal dementia. So putting all these experts together, both for clinical research, clinics, education, and research is really the foundation of the Center for Neurodegeneration. So welcome, Dr. Torres Yagi and Dr. Musa. It's so good to see you both. And it's nice to see you too without a mask on. So this is nice. I get to see your full face and get to see your smiles, etc. So I'm going to start off first with Dr. Torres Yagi. Can you tell us about the stages of Parkinson's? So oftentimes when we first make the diagnosis of Parkinson's disease, we get asked by our patients about the stages of Parkinson's. So why don't we start with the foundation about the stages of Parkinson's there. So and if you can kind of give us a highlight of these stages and what they're called.
Thank you. That's an important question we get a lot in the clinic as well, especially when we first diagnose somebody or when we're trying to determine if medication is working and how fast things are progressing. And what I tend to say, to my patients is, first of all, the stages that we use are very much based on your motor symptoms, right? And so we have what's called the Hoehn-Yahr staging. And it's a staging process that stages from 1 to 5. And so when we diagnose someone, we're trying to determine, one, the extent and severity of all of the symptoms that come from all of the motor symptoms in terms of the criteria for Parkinson's disease. And then we want to determine whether or not patients have unilateral or bilateral symptoms, and whether or not the gait is impaired and to what extent the gait is impaired. And that understanding helps us determine which stage we're in. And so starting off with Hoehn-Yahr stage 1, stage 1 means you have symptoms of Parkinson's, could be tremor, rigidity, slowness of movement, that's affecting one side of the body. So unilateral symptoms is a stage 1. Stage 2 means that you have bilateral symptoms. And that means that you might have tremor maybe on both sides of the body, stiffness or rigidity. Both sides. Stage 3, interim sort of gait impairment. And what gets you to stage 3 is, if you all remember, when we walk down the hall as part of our unified Parkinson's disease rating scale, and one of the things we do is watch our patients walk down the hall, come back. Sometimes there's traffic in the hall. That part of the exam, sometimes we're looking for is the way you walk. Pagan, or one of the other movement disorders doctors, will pull back and see what your postural stability is like. So they'll ask you maybe to face the wall, and they'll stand behind you and give you a practice pull and just give you an understanding. Say, well, I'm going to pull a little harder now. We pull a little harder, and if there's difficulty with standing, or there's more than 2 steps back, or you would fall if not assisted as we pull back, then we say that that's a positive pull test and that there's gait instability. And so if there's gait instability, that moves us to a stage 3, usually indicating that we need something like a cane to walk so that we remain stable while walking. Stage 4 means that we might be using an assisted device that's more advanced, or that we're using something like a walker. And then stage 5 means that essentially it's hard to walk even with assistance, an ambulatory device or something else. And so, but those 5 stages are very much dictated by the motor symptoms. And so we tell patients that going by those stages isn't the only way to think about the progression of Parkinson's. We have to think about all of the different factors, including the motor and non-motor features. So there's a lot of things that come into play. And when we utilize medicines, the medicines can sometimes change somebody, maybe from a stage 3 to a stage 1. You know, if someone is in an on state and their medicine's on and working, a lot of hope there that our medicines can actually move us within that staging process from a more severe stage to a lesser severe stage.
Thank you so much, Dr. Torres Yagi, about the different stages. So we definitely can see progression of these stages from the first time of diagnosis. And sometimes we'll be able to diagnose somebody who is very early with minor symptoms in stage 1. And after several years, maybe get into stage 2. What we've learned is most people will live with Parkinson's most of the time in stage 2 to 3 is where the majority of patients are, while we're treating them as movement disorder physicians. One of the things that we've done with the Translational Neurotherapeutics program, Dr. Musa, is that we've really studied different stages in different research trials. Can you tell us about the different research patients that we've done in different trials? What type of stages we've used in clinical trials? When we're looking at disease-modifying therapy, what's the most appropriate stage to potentially look at those particular, when we study particular drugs that we're trying to slow down disease progression, which stage may be the most appropriate to really look at those patients? And finally, is there a way, do patients progress faster at different stages, or can we use that for a prognosis, or we're still learning about that? So I know a couple of questions there, but maybe put into light first where we tend to do clinical trials and looking at the different stages. What's been your experience? You're probably one of the most experienced clinical research doctors probably in the world with Parkinson's. So why don't you talk a little bit about the stages and what we kind of tend to do?
Some patients in stage 1, they might stay in stage 1 for up to 10 years. And these patients are very highly likely to opt out of any treatment very early on because they don't feel that the disease is annoying them. It might annoy their partner more than them because they see the changes in the other person, but the patient, him or herself, did not see it much because it was a subtle kind of if you like onset of symptoms. Now that's what we normally do for disease for symptomatic therapies. Now for more disease-modifying therapies, because the duration of the stage 1 of the disease varies. So some patients might take 3 to 4 years to basically start moving from stage 1 to stage 2. And some patients may take 10 years. So if you want to treat symptomatically, it's okay to treat symptomatically in stage 1. But if you want to treat with a drug that can modify the disease, meaning it interferes with the biology of the brain, it interferes with the mechanisms in the brain that control our movement and our motor behavior, then you want to be in a stage where you are sure that the patients have already started to progress, because it would be deceptive to give a drug to a patient in stage 1, thinking that this is disease modifying, where the natural progression of the disease is really not It's not really, it will not surely lead to progression into phase 2. Now, when patients go into phase 2 to phase 3, particularly in phase 2, 2.5 to 3, as Dr. Yagi explained, that is the fast progression of disease, of Parkinson's disease. Why? Because once one symptom sets in, there is definitely some biological process that is disrupted or impaired in the brain. Then in phase 2 or in stage 2, there are more than just motor symptoms that start to take place. So it could be cognitive, and it could be autonomic, or it could be, as we understand Parkinson's today. Back in medical school, when I graduated medical school, they used to say it's a motor behavior or a motor problem. But now we don't think the same. We think Parkinson's disease is a disease of the whole body, and the whole body has to be treated. So in phase 1, this whole body problem is not really there. But in stage 2, yes, it is there. So any progression or worsening in the cognition of the patient is actually going to impact their motor ability, or any problem with the behavior, or with, let's say, with the autonomic functions, including constipations, anything that affects the quality of life of the patient as the disease worsens. Then any of these symptoms worsen. The cardinal feature of Parkinson's disease, which is motor, actually also worsens. So also, when the patients move from stage 1 to stage 2, there is a requirement that not only you have to increase the level of levodopa that initially patients take in the stage 1, but now there is a requirement to include other medications to treat other symptoms associated with the disease. So because of the almost certainty that in stage 2, particularly 2.5 to 3, there's about 2 to 2.5 years when the patients really decline, because the efficacy of levodopa and other medications are also diminished at this stage. We interfere with disease-modifying therapies. Disease-modifying therapies are supposed to be drugs that in the patient population that is receiving the standard of care, we are supposed not to see any progression of the disease. We would be very lucky to see reversal of symptoms, but it is hard to see when you are already treating symptoms with levodopa. So what you want to see stabilization or halt, or cessation, if you like, of the progression of the disease. That applies to both cognition and motor, and in certain cases, we want to see other, symptoms basically reversed. And we can treat them. A lot of other treatments exist for non-motor and non-cognitive issues. As the patients go into stage 4 and 5, it will be very hard to basically tell whether a therapy is symptomatic or not, because most of these patients at the later stages of the disease, levodopa is not very effective. So a disease-modifying therapy at the later stage of the disease can tell you a lot more than it can tell you in the earlier stages of the disease. So at the Translational Neurotherapeutics program, our phase 1 study was in stage 4 to 5 patients. And in stage 4 to 5 patients, we saw that certain drugs that we believe are disease-modifying drugs, okay, and particularly in patients that who basically were not responding to the standard of care, we saw reversal and improvement, as much as we could see improvement at after 6 months of treatment. We also studied stage 2 to 3, and that's when we actually saw that when patients are optimized on a treatment, including anything that exists out there that Dr. Pagan and Dr. Yagi and the fellows have given to patients, that over 2.5 years, there was no progression and no worsening in the cognition or the motor symptoms of these patients. So, it's very important to understand that, the intervention in the clinical intervention will really depend on whether we are pursuing a symptomatic versus a disease-modifying therapy. And we really need to understand the natural progression of the disease, at what stage, the disease is likely to progress, so we can administer the appropriate medication.
So I think Dr. Musa brought up a lot of important points. The first important point is Parkinson's patients progress at different intervals. So when we look at Parkinson's disease, the term Parkinson's disease, there's probably many diseases that fall under that. But in clinical trials, a lot of the symptomatic treatments usually involve patients who are usually in stage 2 or 3, or they have a significant amount of motor disability and sometimes cognitive disability. So we can actually test for certain treatments to see if those symptoms improve. When we're doing some safety studies, sometimes especially when there's a new drug, we may start with real advanced patients to look at safety. And that's what we've done in a translational neurotherapeutic programs, where we've been able to test stage 4 and 5 patients for safety. And then we move it up a little bit to more standard of care for further safety in stages 2.5 and 3. And then ultimately, when we're looking for a true disease-modifying treatment, where we may not really see a significant amount of symptomatic treatment in terms of tremor and stiffness and slowness of movement, but we're looking to make sure that we can slow the progression down. Those are disease-modifying treatments. A lot of those patients are going to be early, like stage 1, stage 2, usually, and usually within 4 or 5 years of diagnosis, or sometimes even sooner, when we're looking for true disease-modifying therapy. So Dr. Musa really gave a nice, great overview of those principles that are done in research. So, and definitely both you've heard Dr. Torres-Yaghi and Dr. Musa talk about the fact that Parkinson's is both a motor and a non-motor disorder. And what are some of the treatments right now? So we've had several new treatments come out even during the pandemic, and within this past year, we've had a new treatment come out as well. Can you highlight some of the new treatments, really focus on the motor aspects of Parkinson's? When we think about the motor, we're talking about tremor, we're talking about slowness of movement, rigidity, etc. So Dr. Torres-Yaghi, can you name some of those newer treatments that have come out, and then maybe highlight what we anticipate will be available towards the end of this year and maybe early next year?
Such an amazing question. And Dr. Pagan always says that, there's so much hope in the field of movement disorders. And the hope comes from exactly what Dr. Musa mentioned in terms of clinical trials and research and the momentum behind all of these new and advanced therapies that continue to become available. And that's where a lot of our optimism comes from as well. You'll see the residents and the fellows very excited about learning about the new therapies for Parkinson's disease. And so it's a very important field to be part of, especially when it comes to new therapies. Even during the pandemic, Dr. Pagan and I were talking earlier today, about what happened, during the pandemic in terms of what made it through clinical trials. And two of the medicines that became available were medicines to treat off periods in an as needed or on-demand fashion. So you may have heard in our clinics talking about the inhaled levodopa, which is also called Inbrija, which you inhale 2 capsules as needed up to 5 times a day for patients that are experiencing wearing off. And the idea behind it is that you inhale it, it bypasses the gut, goes from the lungs to the blood to the brain, and it treats your Parkinson's symptoms. Another way of thinking about off is it's a return of your symptoms in between your carbidopa-levodopa regimen, right? Or if you have a high protein meal and you feel like your symptoms are returning, you could do something like inhale this levodopa, and that can help get you back to an on state or alleviate your symptoms, your motor symptoms and non-motor symptoms. Another thing that became available again during the pandemic, and you can imagine all of the work that in clinical trials, that came before it, but a sublingual apomorphine medication. It's a little strip that goes under your tongue and then is administered over a 30 to 60-second period. And what it does is, again, it's utilized to get us out of those off states. And so that's something that became available. Actually, when I was a fellow, I was a sub-investigator with Dr. Pagan. He let me learn how to become a clinical trialist, and that's part of the reason why I'm with Dr. Musa as well, still working with them, is because of the research that I was part of as a fellow. Both of those therapies, the sublingual medicine and the inhaled levodopa, they became available since I was a fellow between 2015 and 2017. They were in clinical trials, and they launched not long after, and now we have them to utilize for all of us. And so we pioneer things in many academic centers at Georgetown because of our affinity towards doing all of this research. It helps us get us right there on the forefront. As soon as something becomes available, when it's transitioning from clinical research to clinical practice, we're ready and we've utilized it and we've learned about it and we know how to counsel our patients. And so that's part of the wonderful part of being part of our practice and this whole ecosystem, this fund-to-fellow ecosystem. The third drug that became available is called Neurians or istradefylline. Now that's not utilized in an as-needed fashion or an on-demand fashion. That's what's called a maintenance adjunctive therapy. So you utilize it in addition to the carbidopa-levodopa regimen that you're on to reduce off time and improve on time. So just improve your time throughout the day and create stability. So the wonderful, three medicines that have become available have really happened in the pandemic. Now, to answer Dr. Pagan's second question, or the second part of his question, is what are we hopeful about? What do we know about, in terms of our clinical research and knowing what might become available? The first thing that comes to mind is based on a study called the Toledo study, which looked at a therapy that's already available in European countries. And it's an apomorphine pump. And it doesn't pump into different parts of the body like we have with Duopa. It goes through a tube that goes into your gastrointestinal system. This actually pumps apomorphine into your skin on a continuous basis, making it a lot less invasive. You can think about it as a patch pump with a bunch of these kind of microneedles that attach into your skin so that you can continuously pump apomorphine. Apomorphine, now don't get confused with morphine, right? Apomorphine is a dopamine agonist. We're used to dopamine agonists in Parkinson's disease. If we've heard of the Nupro or ortigatine patch, Mirapex, Pramipexole, Ropinirole, and Requip. And actually, the sublingual therapy that goes under the tongue is also apomorphine. So that's something that's very important and that we're looking forward to. Most likely by the end of this year, we may be able to prescribe that for our patients in the United States and at Georgetown. The other two things that we're looking forward to, one is called a clinical trial, is a 951 clinical trial that we were also a part of, and we are enrolling for now, actually, for some of our patients. It's another pump that's also subcutaneous, also based on the insulin pump technology that pumps carbidopa-levodopa formulation, reformulated, phosphorylated into the skin, again, on a continuous basis. So the idea behind that is, again, more stability. So we would think about this as device therapy potentially moving forward in the future for our patients. So those two devices are something that we're really looking forward to. And in the future, beyond that, there's a lot more that might become available. We're really excited about a compound called IPX203, which is essentially a super extended release carbidopa-levodopa, but it's a pill, right? So you would take it similar to some of our extended release formulations, but IPX203 might be effective even by taking it 3 times a day in patients that may have been on carbidopa-levodopa immediate release many more times than that throughout the day.
Yep, exactly. Thank you for that great overview. So what's interesting about the pumps is really using the same type of technology that has been used in the diabetic world. So they look like insulin diabetic pumps, really what that's the same type of technology. And the pump that was used in the Toledo study and now the 951 is identical. So once one of these pumps gets approved, we may be able to prescribe 2 different drugs, whether it's an apomorphine subcutaneous or phosphorylated carbidopa-levodopa. So it's a subcutaneous continuous infusion of these medications. Same type of philosophy behind diabetes, the type 2 diabetes and insulin, or type 1 diabetics as well, who are on continuous insulin. So these, so we're looking forward to that. And the IPX203, as Dr. Torres-Yagi mentioned, is interesting because this also lasts longer, but a quarter of the pill is immediate release, and the 75% of the rest of the pill kind of binds to the small intestine and slowly releases that carbidopa-levodopa. And the 86% of patients only needed to be treated 3 times a day in that particular clinical trial. So we'll take a look at what the future holds. But these are all motor symptom relief. Not only have we seen continued expansion in ways to treat the motor symptoms and deliver therapies more effectively in Parkinson's, we've also seen a significant amount of disease-modifying therapy trials really start up. And Dr. Musa, can you highlight some of the research looking at disease modifying for the different types of neurodegenerative disorders? You could also highlight potentially what we just learned at Georgetown with Lewy body disease, and you have an exciting presentation about Lewy bodies coming out in the near future. We just submitted a paper, so maybe it could at least just highlight some of the things that will be coming out in the near future.
Yeah, thank you. So I could see how exciting it is to develop a drug that, as Dr. Yagi said, a super continuous release levodopa, sublingual. All these drugs are great as disease-modifying drugs. But put it this way.
Or motor symptom relief.
I mean, motor symptoms. I'm sorry, Dr. Pagan, I apologize, motor symptoms, because my obsession is disease modification. But put it this way, okay? Whether it's good to be able to take the drug once a day, not 5 or 6 times a day. It's perfect to reduce the dose of the drug from like 500 milligrams levodopa to 200 milligrams levodopa if you can. But at the end of the day, even though these drugs are relatively slowing down disease progression, you still are going to see in the patient the stage 1 versus stage 2 versus stage 3 versus stage 4. These diseases, these drugs are exciting because they provide more variety, and not all patients are responsive to all these drugs equally. So probably, this diversity offers better management of the symptoms. What we really are keen to have in the next 5 to 10 years is a disease-modifying therapy that can either reduce the amount of proteins, of toxic proteins in the brain, like alpha-synuclein in Parkinson's disease, or in dementia with Lewy bodies, or amyloid and tau in Alzheimer's disease and other dementias. What we also want to achieve is, and this is a specific, strong focus of Georgetown University Medical Center, how can we get the brain to secrete, to make its own natural dopamine available. So we don't need these dopamine replacement therapies to basically treat the disease. If the brain can make more of its own dopamine and can make more of its own dopamine available, then we will not need, then it's a disease-modifying therapy. So you can achieve that in two ways. Number one is you want to reduce the amount of alpha-synuclein, and I'm talking here about Parkinson's disease and dementia with Lewy bodies. You want to reduce the amount of alpha-synuclein because that means you will reduce cell death. None of the symptomatic treatments are reducing cell death. They're basically saying, okay, if you have 10 neurons or 10 cells that make dopamine and 3 of them died, okay, then you have 70% of the amount of dopamine in the brain. So if I give you levodopa, I can replace the lost 30%. But more time goes by, more time means more progression. So not only 3 cells will die in 5 years, maybe 5. So you have 50% less dopamine. So you need to give the patient more dopamine. Disease modification is when you reduce the level of alpha-synuclein, you prevent cell death, okay? That's one thing. There's a lot of clinical trials right now looking at this. There's almost 6 different clinical trials outside of Georgetown University with big pharmaceutical companies. I won't go into each one of them. All of them are looking at 2 different things. Either at basically silencing the gene that expresses alpha-synuclein, and therefore there would be no increase in alpha-synuclein and no Lewy body formation in the brain. Another approach is developing antibodies that would interfere with the native folding of the protein. So instead of becoming toxic, the protein would remain to be like a housekeeping protein. All six clinical trials right now are in phase 1 and phase 2. There's none that has progressed to phase 3. There's only one company that actually is doing phase 2/3 trial called Prothena. It's an Irish company that's developing an antibody that would interfere with the misfolding of the protein. Unfortunately, so far there is no company and no development of a drug that would protect dopaminergic neurons, dopamine-producing neurons, to basically reduce the burden of an increase or the necessity to increase levodopa. At Georgetown, what we've done, we have now 2 candidates. Candidate number 1 is called nilotinib, which most of you know about it. Okay, again, we treated patients who were in stage 2.5 to 3 for 27 months. Over 27 months, there was no progression in cognition or cognitive impairment, and there was no progression in motor impairment. So when we looked at the level of particularly dopamine in these patients, we see that the drug reduces the breakdown of dopamine. So regardless of how much dopamine is actually being produced in the 70% of the neurons that are left or remain in your brain, whatever dopamine is secreted or is made, the drug is preventing their breakdown, so it's keeping the level of dopamine high. Over 27 months, there was no need to increase the level of dopamine in these patients, and there was no progression of the disease. There is another drug that we just Dr. Pagan mentioned it, called bosutinib, which is a very similar drug that we're studying at Georgetown. This drug is also a leukemia drug. We used it in Lewy body dementia. And what we see in this drug, it is the first drug that we know of that reduces the level of alpha-synuclein in the brain. That is an incredibly encouraging data to showing that, there was no change or no increase in alpha-synuclein whatsoever in the positinib treated group versus the group that was not treated with positinib. And we are talking about only 3 months of treatment. In addition to the reduction in the amount of alpha-synuclein, there was a significant increase in dopamine. And the dopamine that we see not only is increased in the brain, but there is also an increase of dopamine in the periphery, in the blood. Meaning what Dr. Torres-Yagi was talking about, a lot of these pumps, which require particularly for example, the Duopa pump that has to be inserted in the patient's body, particularly in the later stage of the disease, we probably will not need something like that if we can give the patient just a pill or a capsule and then increase their dopamine level. So we increase their cognition, we increase their motor behavior, motor capacity, and we'll also treat a lot of the gastrointestinal issues. There's another drug that we are studying called KO-706, which is very similar. And all of KO-706, positinib and nilotinib are basically, they have one common mechanism, which is called autophagy, or clearance of these toxic proteins from the brain. And when you clear these toxic proteins, you reduce inflammation and you seem to improve the level of dopamine in the brain. So these are basically generally what we're looking at as disease-modifying therapies. We here at Georgetown University have been leading the world in these clinical trials. We've finished a trial in Alzheimer's disease. We're going on a phase 3. We finished a long trial in Parkinson's disease, and we've shown some very exciting genomics data and data that show that there is a strong effect of the drug, particularly in the long-term treatment. We are showing that positinib is also a drug that could be one of the, probably what is really now the front line of all the treatments that are being studied for Lewy body dementia. It could be the first drug that really gets into the clinic for the treatment of Lewy body dementia. So there is a lot we are learning about. There is a lot we are producing, and we definitely are leading the movement disorders community worldwide in the way we look at movement disorders, and the way we look at Parkinson's disease as a disease that has to be stopped, not as a disease that has to be managed. So we're good at management. We really want to stop the disease, and that's what the clinical trials are all about right now.
And it's so exciting. We definitely are getting better tools and better weapons for disease management. But definitely, when you take a look at the number of trials that are going on for disease modifying, and some of the early results that we've seen so far in phase 1, phase 2 clinical trials, I'm also excited about the future. One of the questions that we get asked a lot is, well, if I have Parkinson's, am I going to develop Alzheimer's? And really, one of the things we've learned that about half of patients with Parkinson's can go on to develop Parkinson's disease dementia, but Parkinson's disease dementia and Lewy body dementia under a microscope are almost identical. They're very difficult to differentiate the two. The pathology behind it is very similar. So we don't tend to say Parkinson's disease and Alzheimer's disease. We really use the term Parkinson's disease dementia. We pay a lot of attention to mild cognitive impairment in Parkinson's patients. And that's actually one of our brain initiatives. With Dr. Torres-Yagi, we've developed a comprehensive cognition clinic where we look at cognition and cognitive complaints in our Parkinson's patients on a yearly basis. And then we use therapies. Can you highlight some of the things that we do in the Center for Neurodegeneration for the Comprehensive Cognition Clinic, Dr. Torres-Yagi?
It's a really helpful, focused evaluation. You might have heard of it as the CCC Clinic, and it's an adjacent clinic where we are able to really assess for kind of all of the cognitive issues that Dr. Musa and Dr. Pagan were mentioning, not related to the motor symptoms, right? It gives us time to be able to analyze, number one, our patient's cognitive abilities by implementing what's called the Montreal Cognitive Assessment, which tests our executive function, our reaction time, our verbal fluency, the way we can remember words, for example, abstraction. So it's really a test that has 30 points, but it has so much information that tells us what part of the brain is affected. You know, is it more of a frontal lobe function that's affected, a temporal lobe? Does it have to do with the way we store or retrieve our thoughts? Because the cognitive pattern in Parkinson's disease is very distinct, especially in contrast to the other conditions that cause cognitive impairment. So the other things we evaluate for in our comprehensive cognition clinic are, we check for depression. So we do a depression scale called the geriatric depression scale. We'll make sure that our patients aren't experiencing any hallucinations or fixed ideas that could be scary or delusions. We'll make sure that our patients are doing well in terms of their functional capacity. And with the addition of our social worker, we screen for and ask questions about the need for our social worker to intervene and help us with any sort of planning for the future or now. And so it really has helped us. It really is a comprehensive clinic evaluation. Our goal is to be able to do this every year, at least, for our patients, or if we decide to make some sort of therapeutic intervention, we might do this twice a year to make sure that we're on the right track and that the medications are working. And so it's been a really nice addition, especially when talking about our new center, the Center for Neurodegenerative Diseases, and then brain health. The brain health initiative also is very important to us. We have started conversations with the primary care team that's on the first floor about developing a brain health clinic to help us, more of a guidance clinic in terms of lifestyle modifications to help keep our brain capacity strong and flexible and provide longevity for brain health. That really is our goal.
So thank you, Dr. Torres-Yagui. So this is really important for our patients with Parkinson's who have cognitive impairment, or patients with Parkinson's disease, dementia, and our Lewy body disease population. So as Dr. Musa stated, we have active clinical trials for Lewy body disease, and we're one of the few centers probably in the country having these trials. If you know somebody who has Lewy body disease, we're happy to see if they want to be part of our trials. We're still enrolling, and we're very excited about some of the things we've already learned with some of our products already. When it comes to symptomatic treatment and even disease modifying in early Parkinson's disease, we also have clinical trials out of the Center for Neurodegeneration. And actually on this call, we do have, I was going to call him doctor, but he should be a doctor, but his name is Luke Lovelace. And Luke is our director of Parkinson's clinical trials at the CND. Sarah Mader is one of the directors for the Translational Neurotherapeutics program out of the university, but the university also for the CND, I have Luke here. And Luke, can you highlight some of the active clinical trials that we currently have that we're actively recruiting? We have 2 that are disease modifying, and then we have some that are also for active symptomatic treatments. And maybe you can mention some of the ones that will open up in the near future as well.
Yes, I'm honored to be part of the meeting, and So we have a number of trials that are currently enrolling, and then a number of trials that are getting ready to start enrolling. And as Dr. Burgan was talking about earlier, Parkinson's disease dementia, where we have a couple trials that we're hoping to open in the near future. So that's something that I know we're all excited about. The current ones that are enrolling in terms of early Parkinson's disease is a trial called Neurally, which is a once-a-week injection trial of an investigational product called NLY-01. And we currently have 2 subjects in that one and are still enrolling. So that trial has been exciting, but is a little harder to recruit for because we need patients that are very early diagnosed and haven't started any treatment for Parkinson's. The other trial is the ProSeq study, which Dr. Musa knows a lot about. I think he was helpful in getting that study started. And it's with a drug called K0706. And that's also for early Parkinson's disease. And the good thing about that trial is patients can be on a stable dose of rasagiline. So that's always a little more encouraging for patients because when they start a trial and they've just been diagnosed with Parkinson's, they can be concerned about not being able to take any medication, where some of these trials can last up to a year or longer. And then in terms of the new trials, we have a trial with Interin for Parkinson's disease dementia that we're hoping to start soon, which has shown some promising early results for the treatment of Parkinson's disease dementia. Dr. Yagi earlier was talking about 9-5 that I think will hopefully start enrolling in the next month or so. And that trial is with 951, the subcutaneous pump. And patients will actually be sent to Chicago for that trial. And the exciting part about that is if they finish that portion, there's an open label portion of the trial where they can stay on the subcutaneous pump. And that trial is for patients with an increase of off time. So those are kind of the main trials that I think are worth discussing during this meeting, but there's always new trials coming, and we're excited to work with a lot of different sponsors. And most importantly, I really enjoy working with the patients and Dr. Yagi and Dr. Burgan and helping find new ways to treat Parkinson's.
So I thank you so much, Luke. And one of the things that we really wanted to highlight this evening was the fact that there is Parkinson's disease progression, and there's 2 ways to attack Parkinson's disease progression. The first is really with our symptomatic treatments, so we can keep people exercise, keep people moving. We've learned if we keep doing that, we can really slow down disease progression. And then there's treatments that aren't symptomatic, but there's a lot of research going on with these treatments, as Dr. Musa was highlighting, that really makes the field very exciting. As a movement disorder neurologist, I never have to withhold any treatments, because when I look at the pipeline of drugs to come for symptomatic control and disease-modifying therapies, I'm excited about the future. I think one of the things that has happened throughout my career over the last 20 years is that our therapies keep getting better. And what that means, it correlates to improving the quality of life of our patients and their caregivers with Parkinson's. So it's a much different disorder today than it was in the 1980s or 1970s, or for that matter, the 1960s. So we've come a long way. We're getting better and better in our treatments, but I see our armamentarium for symptomatic treatment getting better in the near future, but I'm also very hopeful about the potential of these disease-modifying therapies, especially when I see the exciting work like investigators like Dr. Musa are leading across the world. I want to really thank the whole entire team. A special shout out to Joy Arellano, our nurse navigator with the CND, and also for our fearless clinical coordinator, our center coordinator, and our outreach coordinator, Helen Howard. I'm happy to announce we just went through a recertification of a Center of Excellence by the Parkinson's Foundation, and we got a beautiful new plaque. We got certified once again. And again, this is because of all the hard work of the entire team, and one of our leaders behind the scenes is always Miss Howard, who's always working always working significantly hard behind the scenes every single day. I want to thank our two esteemed panelists, Dr. Charbel Musa and Dr. Torres Yagi, for their insights and all the excitement that is sure to come over the next couple of years here, just really in the near future. Thank you for everybody for your support with Fund a Fellow. I hope our next one, it will be all together and live and in person. And once again, thank you to all the members who make this possible. Stay safe, God bless, take care of each other, and we'll see you next time. Thank you so much.